todas. Iniciaremos en unos minutos.
Good morning to everybody. We will be beginning in a few minutes. Thanks for your attention.
Días.
Good morning to all of you, and welcome to the second virtual seminar of the series on essential public health factors of the Pan American Health Organization, the World Health Organization as well. On a day like today, we will have a chance to hear excellent presentations on the monitoring of universal health in times of COVID-19. My name is Amalia del Riego, and I'm head of the Unit of Health Services and Access of the Regional WHO PAHO Services. And it's a privilege for the organization to have such outstanding group of speakers. Well, actually, we have 3 speakers today, and they will be talking to us to motivate the debate today. As usual, I always like to start with a note of hope and light at the end of the tunnel, I want to share with you that my light at the end of the tunnel for today, the happiness for today, was the message, video, and song that the Director General of the World Health Organization began the meeting, Dr. Tedros, meeting of the organization's staff. The title of the video and the name of the song was Universal Health. For me, no better way to start my day, because the topic that we have today, which is the monitoring and evaluation of universal health, and the series of essential public health functions seminars are for a very specific reason in mind. They have one goal, one purpose, which is to advance as a region in all our countries to achieve universal health for all, everywhere. We'll begin, as I mentioned, we have 3 speakers, and we'll begin our first presentation with James Fitzgerald, who's director of the Health Systems and Services of PAHO. And then we'll hear Catherine O'Neill, who is head of the evaluation of Health Service Performance Department and Integrated Health and Universal Coverage for the life course of the WHO. And we'll end with Sebastián Garcia, director of the Evidence Intelligence for Action in Health in PAHO in our region. At the end of the presentations, we'll have time for questions and answers for the speakers. Also take into consideration that you can be sending your questions at any time during the webinar through the chat or the Q&A. Before we begin with the presentations, I just want to have some of the administrative aspects, the housekeeping aspects. I want to tell you that we have simultaneous interpretation into English, Spanish, and Portuguese, and sign language. Please choose the language of your choice. Also, we remind you to adjust your view, gallery view, so that you can see the presentations and the sign language if you need. And finally, to remind you that we will be keeping all our microphones muted to make this activity better to carry out. With no further ado, we're going to invite Dr. James Fitzgerald, who's director of the Health Systems and Services of PAHO. And he's my boss and responsible for overseeing the work program of the organization on policies and health governance, systems and health services in human rights, financing, access to medicines, and health technologies. James is a pharmacist with a doctorate in pharmaceutical sciences from the Goodland University and has a long history of more than 20 years in PAHO WHO. He's the author of many articles. Welcome, James. You have the floor.
Thank you very much, Amalia. A very good morning to you, to my fellow panelists, and of course to everyone connected here this morning. It's a real pleasure to be able to participate in this important event, where in fact we are launching the monitoring framework for universal health in the Americas. I think there's no more important time that we introduce a framework such as this when we've seen COVID-19 have such devastating impact on the health and well-being of all populations in the Americas. Our health systems have been challenged. They have surged capacity, but we've seen the results of structural deficiencies in health systems as a consequence of this pandemic. Next slide, please. In my presentation then this morning, within this context, I wanted to walk us through what we actually mean by universal health. Amalia presented very well the issue in terms of the overarching concepts that is growing now within WHO, and how we see universal health, its need, its purpose, the overall frameworks that we're working to as we seek to improve the evaluation and monitoring of capacity within our health systems. What approach has been developed and how we intend to apply and align these tools with other existing frameworks that exist. Next slide, please. So first of all, a comment on universal health. When Dr. Etienne, our director of the Pan American Health Organization, assumed the leadership of the organization in 2013, she posed a very important question to our governing bodies at that time. And that question was the following. It was, what does universal health coverage mean to the Americas, mean to countries that have enshrined either in constitution or legislative frameworks the right to the highest attainable standard in health as part of the overarching mandates within constitutional frameworks and legislation. What does this concept of universal health coverage mean within that construct? And so we initiated important dialogues with countries on this issue, recognizing the very different health systems that exist within the regions, the structures, the organizational models, the mechanisms of financing. And the countries came back to us in 2014 with a proposal to say that yes, universal health coverage or universal health coverage being those inputs that are required to ensure the provision of health services are important. But what we really need is universal access to health, whereby we break down the barriers to health, to improved health and well-being within our communities, within our countries, and whereby we really move to expand this access to include everyone, to make sure that we leave no one behind. And so in that meeting of the governing bodies of 2014, the member states of the Pan American Health Organization adopted what we now refer to as a strategy on universal access to health and universal health coverage. And this has become known within the organization, within the region of the Americas, as universal health. It essentially means that all people and communities have access without any discrimination to comprehensive, appropriate, timely, quality health services and without suffering financial hardship. It's based on the principles of the right to health, solidarity, and equity, and it really encompasses issues around addressing the social determinants of health. In that discussion, the member states also adopted 4 strategic lines of action to transform health systems. First of all, to expand access to comprehensive integrated health services based on the primary healthcare approach and built on the promise of integrated health service delivery networks. To increase financing and to progressively eliminate out-of-pocket expenditures, to strengthen intersectoral coordination, but most importantly, to strengthen stewardship and governance towards the achievement of universal health. And no more so have we seen in this time the importance of stewardship and governance as countries have been challenged with the COVID-19 pandemic. Next slide, please. So let's look at some numbers. We have seen that health systems in the Americas are highly segmented. They are highly fragmented in terms of their capacity to ensure continuity of care, segmented in the capacity of different populations to ensure equity and access to health services and to address their differentiated needs. Unfortunately, we have low levels of public financing in health, improving, but improving slowly, only reaching about 4.1% of GDP as expressed as a percentage of public expenditure as a percentage of GDP. Our human resources for health, they're not distributed adequately. We have imbalances in access between urban, peri-urban, and rural areas. And access to health technologies, and in fact, health technologies now constitute one of the principal drivers of out-of-pocket expenditures in the region of the Americas. All this translates into a number of important outcomes in terms of high levels of avoidable mortality, high levels of foregone care, poor quality within the health systems, enormous differences in the gaps between the rich and the poor, and ultimately, the risk of impoverishment through high out-of-pocket expenditures and catastrophic expenditures that persist within our health systems. Next slide, please. The situation has been readily exposed by the COVID-19 pandemic. The pandemic has really highlighted the structural deficiencies within our systems and particularly impacted the provision of what we refer to as essential health services. 49% of countries in the Americas, through surveys that we've completed from period of November to March of this year, reported disruptions in essential health services, those services that are required not just to tackle the pandemic, but to ensure provision of immunizations, maternal child care, to address disease detection and control, to improve HIV, TB, malaria, and of course, non-communicable diseases. In particular, our primary care services have been impacted most significantly, with 51% of countries reporting disruptions. And why? Well, we essentially know that fear and distrust within the context of the COVID-19 really resulted in a significant reduction in people seeking care. We had restrictions in transport that impacted people's accessibility to health services. We had shifts in the health workforce into more specialized care settings to tackle the pandemic. And we've reported persistent barriers in access to care, substantiated either through out-of-pocket payments or lack of geographical access to health services during this time. Next slide, please. And so it's within this challenge, within this context, that we are now moving forward to see how we can better monitor not just the performance of our health systems, but the overall factors that impact access and coverage within health systems in the Americas. The monitoring and evaluation framework that we're launching, it is really important for us to be able to see the impact of policies on the transformation of health systems and what is the result of the impact of those policies. The framework has been developed through a consensus-based process in consultation with countries, looking at analytical frameworks that will facilitate not just collaborative efforts and the analysis of the current context, but it will also feed into the generation of evidence that will result in further transformation within our health systems. This is a complex process that requires institutional, political, and intersectoral buy-in and the necessary mechanisms to evaluate the health systems transformations that are ongoing in the Americas. And until now, there has been no regional proposal for the Americas that fully addresses the issue of coverage and also access within our health systems. Next slide, please. The process is extremely closely linked with the essential public health functions. You will recall that we launched the renewal of the essential public health functions in December of last year, in fact, at Universal Health Day. The assessment process is necessary as a mechanism to strengthen the national health authorities' capacities to understand health population needs, to develop the necessary policy development processes, to assign the necessary resource allocation, and in this way to ensure access to health. And so this policy cycle that we have developed around the essential public health functions is extremely closely linked with the evaluation and monitoring processes now that we are moving forward with. It therefore provides us with the necessary input in decision-making that we hope will ultimately improve in the conditions, the living conditions of people, particularly when it comes to accessing health. Next slide, please. And so our purpose here is to provide a framework that is consensus-based, to continually evaluate advances in the region towards the achievement of universal access to health and universal health coverage. It will help national health authorities understand the impact of the policies that are being developed and implemented within the region that directly have incidence on access and coverage conditions within their countries. And it allows, based on the generation of this evidence, the engagement of national stakeholders and policy decision makers moving towards this overarching goal of universal health and the achievement of the Sustainable Development Goals. Next slide, please. The framework is quite a simple framework. We take the strategic actions that have been adopted by our member states in 2014 around the expansion of health services, increasing and improving the efficiency of financing, eliminating out-of-pocket expenditures, looking at governance issues and intersectoral coordination. And they are broken down then into outputs, outcomes, and then the overall impact in terms of population health. In terms of output, we're looking at critical systems resources, aspects relating to the organizational health services, and then those intersectoral interventions that will directly impact health. In terms of outcomes, we've already seen in our last webinar the discussion around access barriers, and these outcomes are extremely important in how the changes within health systems will directly impact access. We look at areas of coverage and use of health services, and also coverage and use of intersectoral actions within health systems. The impact will be seen probably in a longer period of time over population health and well-being. Next slide, please. The approach really builds on a combination of strategic actions, the indicators, either output, outcome, and impact, and whereby we have worked with experts and countries around the region over a lengthy period of time in identifying the necessary quantitative indicators, some of them being tracer indicators, to measure equity, the principle of equity in access and coverage conditions. And this we combined them with some qualitative evidence that is required really to provide context to the quantitative tracer and equity indicators that are being presented. The qualitative evidence is necessary to provide that context to describe the actions and the impact of policies that have been implemented in the region of the Americas in health systems and the multiple transformations that are ongoing. Next slide, please. The implementation framework has been rolled out in a number of countries. Some countries are more advanced than others in its implementation. It is very closely linked with the processes by which we are also rolling out the monitoring framework for the essential public health functions. And so we see a variety of countries adopting some processes to apply the monitoring and evaluation framework jointly with the essential public health functions to really generate that evidence base that will guide them in developing the necessary capacities within health systems to improve access and coverage, but also to be better prepared for the future with regard to future pandemic response capacity. Next slide, please. We have been very careful and are very aware of the importance of ensuring alignment with other existing tools. And we're very aware that multiple tools do exist that are important for countries to be able to very much guide health systems and health sector reform processes. We within the monitoring framework for universal health are focusing on indicators relating to access and coverage, and these are very important as we also move forward in measuring the SDGs. It's based on country-based monitoring and evaluation exercises that will ultimately guide countries in taking decisions with regard to policies and actions for health sector reform. It is very much aligned with the UHC and the SDGs global monitoring framework, and will feed into that, and particularly the health service coverage index and the financial protection indicators. It's also very much aligned with the essential public health framework, the essential public health functions framework that looks at the measurement of public health capacities, really focusing in on the governance and the policy cycle that examines access and coverage from a broader aspect of the essential public health functions. This again is country-based, looking capacity building exercise with a much broader intersectoral area of action to strengthen public health capacities in countries. And most importantly, we've seen the role and the importance of primary health care really to recuperate lost public health gains in the future within the context of COVID-19. And the monitoring framework will be very much aligned and is aligned with the PHC monitoring framework that is currently being developed by WHO and will be implemented also within our region. Next slide, please. And so we're very happy to launch this today. I really want to congratulate all the countries that have participated in this process so far. I want to congratulate all the experts that have contributed to this process. It has been a lengthy process. Gone through extensive internal consultation also within the organization. And I really want to congratulate Amalia and the team also for bringing this product to fruition. I do believe it will be a very important tool for countries to apply at the national level to examine performance of health systems, to look at the gaps that exist, and to generate the necessary evidence that will be required in inducing further health sector transformation to ensure improved equity and access in health in the region of the Americas. Next slide, please. So I will leave you with that. My thanks to you all. This is a very exciting moment for us. We're really happy to be able to present this for you today. And we really look forward to working with you all, particularly at the country level, in rolling this very important initiative out. Amalia, back to you. Thank you very much.
Muchas gracias, James,
Thank you, James, for this presentation. And also for sharing with all the fact that we finally have the monitoring framework for universal health. It's been released and is available for use in the Americas, and hopefully you will have access or will be at least interested in looking at it. Thanks you, James. And now with this, we'll go to our next speaker, Catherine O'Neill, who's head of the performance evaluation of the health services at WHO. Catherine has an outstanding history, more than 20 years in public health and internationally. Currently, she leads the work at the WHO, strengthening the metrics, evaluation, and follow-up of health services, including quality, resilience, and performance of health services. She also is in charge of coordinating the work at WHO of measurement and follow-up of the performance of primary health care, work which she'll talk to us about now, and we know for a fact will be of interest to all of us in this region, thanks to the long history she has in primary health care. Welcome, Catherine. It's a pleasure to have us with you, and thank you for sharing this webinar with us today. Catherine, you have the floor.
Thank you, Amalia. Good morning, everyone. I'm delighted to be here today to participate in this webinar with you. I'm also very happy to have the opportunity to introduce the upcoming publication from WHO on primary healthcare performance measurement and monitoring. And I think this actually sits very nicely beside the framework, the UHC monitoring framework that James and the team have just developed and presented, and focuses in more on the primary healthcare service delivery components. Next slide, please. So first, a brief context, and I'm sure many of you are aware of all of this, or most of you are. As we know, the declaration of Astana in 2018 and the subsequent vision document puts forward a comprehensive approach for primary healthcare in the 21st century, with these three interrelated and synergistic components. One that meets people's health needs across the life course through integrated health services, with the emphasis on primary care and essential public health functions as critical elements, as also mentioned by James. Two, that addresses the broader determinants of health through the evidence-based multisectoral policies and actions. And then thirdly, that empowers individuals and communities to be more involved in decision-making about health services and about their own health needs. So in 2019, WHO member states
En el
reaffirmed
2019, los Estados miembros de la OMS,
can you hear me okay?
ahora se escucha a la señora, por un momento desapareció el sonido. Está prendido.
Can you hear me okay? Shall I continue?
¿Me escuchan?
Yes, Catherine.
Sí, se la escucha, señora.
Okay. So in 2019
En
then,
el 2019,
WHO
la OMS
member
y
states
sus
reaffirmed their
Estados miembros
commitment to the
reafirmaron su
vision of primary
compromiso,
healthcare
la visión de la
as a
atención
vehicle
primaria
really
de
for
salud
achieving a universal health coverage and the
y el
SDGs,
esfuerzo para lograr la cobertura universal de salud.
and called upon WHO
Y
to
le
develop the
pidieron a
operational
la
framework
OMS
for
que
primary
desarrollase el
healthcare to
marco
support country
operacional para la atención
efforts
primaria
to
de salud
translate
en
this
apoyo
vision
de
into
los esfuerzos de
action,
los países para transformar
to
esta
develop
visión
a
en
measurement
medidas
framework
para
to
desarrollar
support
un marco
monitoring
de medición
progress, their
para
own progress
apoyar
and
el
advances
monitoreo
in
del
primary healthcare
progreso y
strengthening,
los adelantos en
and to
el
report regularly
fortalecimiento
to the
de
World
la
Health
atención
Assembly
primaria
on
de salud e
progress.
informar en forma regular a la Asamblea de la OMS sobre los progresos
I will
realizados.
pause here because I believe
Haré
that we're
una pausa
hearing
aquí
both.
porque creo
I
que estamos
believe we hear both English and Spanish translation at the same time. Can I have a check with?
Okay, so Spanish is good now.
Shall I proceed?
Yes, you should continue.
Great. Okay, so in terms of the operational framework that WHO was asked to develop, then it was published. The operational framework for primary healthcare was published last summer, in 2020, to address these three components of primary healthcare. And it proposes a set 14 strategic and operational levers that can be used to guide progress and improvement in health systems, in this primary healthcare oriented health systems approach. The levers, I mean, very much match to the traditional health systems building blocks, ranging from the political commitment, leadership, governance, funding and allocation of resources, engagement of communities and other stakeholders, which is very important, and then to these operational components around the design, management of models of care, the primary healthcare workforce, the infrastructure, the availability of medicines, engagement with private health sector providers, which is increasingly important, the purchasing payment systems, digital technologies, systems for improving the quality of care, and research and monitoring and evaluation. And in this framework, the levers are accompanied by a set of actions and interventions that can be applied at policy, operational, and implementation levels to help guide countries' efforts to strengthen primary healthcare oriented systems. And the desired results, of course, then are the improved access, utilization, and quality, improved participation, health literacy and care seeking, and of course, the improved determinants of health, all as a vehicle as on the critical pathway towards achievement of universal health coverage and the health-related SDGs. Next slide, please. So moving on to the monitoring framework. So that has been developed over the past year to accompany the operational framework and the monitoring across the levers and the different components of primary health care. This has been developed with broad consultation and is being finalized currently, and we hope to have it published over the summer in September of 2021. The primary purpose of this is to strengthen countries' capacity to track and monitor progress in primary health care performance in improvement by providing a menu of indicators that can be like a basket of indicators that can be drawn on by countries and tailored to their specific contexts, to their specific priorities, and corresponding to the maturity of their health system and their corresponding health information system. It also attempts to provide operational data that countries can use to assess, plan, manage, and prioritize actions and interventions that are linked to those strategic and operational levers. And the framework also attempts to address these sort of hitherto under-measured domains in primary healthcare, which have always been challenging, relating to, for example, quality of care, patient experiences, the integrated approaches to models of care. The second objective then is to try and align this with national planning and review processes and provide and align with sort of the national and global monitoring efforts for universal health coverage and SDGs. And I think James has spoken to this objective, and we really are trying to align where the primary healthcare piece lines up with these the UHC and SDG monitoring, so that we can provide a comprehensive, coherent approach to monitoring for primary healthcare within this whole framework, with this whole approach. And then the third objective then is to recommend a very small set of indicators that can be used to support global tracking of progress in strengthening primary healthcare within the context of universal health coverage. Next slide, please. So this is the proposed conceptual framework for monitoring and evaluation of primary healthcare. The framework illustrates sort of the logical relationship between the health systems determinants, so these structures and inputs on the left-hand side, to service delivery, the process and outputs, and then links it ultimately to the desired health system results, outcomes, and impact. The framework incorporates the three components of the primary healthcare approach and aligns the levers into the sort of traditional results chain framework. So I think, so what it tries to illustrate is this causal pathway or direction of influence that link the investments, actions, and interventions that we undertake in terms of governance and infrastructure and workforce and medicines and models of care to improvements in access, availability, and quality of care. And that in turn will lead to better coverage, health service coverage, effective service coverage, financial protection, health security, and health status and equity. And throughout the framework, it highlights how those critical elements of quality, equity, and resilience are assessed and measured across the whole results chain. But the main focus of this framework is really where the dotted line, within the dotted line, really looking at the structures, inputs, processes, and outputs. But as I said, as we believe PHC is on the critical pathway for universal health coverage, we've embedded it and aligned it with the broader health systems performance and UHC and SDG monitoring approaches. So next slide, please. So with this framework, and then we have proposed a menu, and as I said, a basket of indicators that countries can draw from. And they can help them address a set of questions to identify these gaps and create those kind of nudges that are needed to drive change, to drive improvement. So for example, with such a framework and the indicators that are there, countries can assess whether policies are oriented towards primary healthcare and universal health coverage, if there are mechanisms for the community and multisectoral engagement, if spending has indeed increased on primary healthcare, and if the resources that are allocated are based on a evidence-based situation analysis and targeted to reach the most vulnerable. We can moving across the framework, then we would expect to see health facilities having more secure or more accessible and meeting standards. If there is an adequate and trained primary care workforce that also have teams for multidisciplinary approaches, that if the availability of medicines diagnostics improved. And I think one of the newer components of this framework is really focusing in on these models of care, looking at measures to assess whether countries have developed comprehensive service and health benefit packages that have been defined to support the whole life course needs, the health needs across the life course, from promotion, protection, prevention through curative, rehabilitative, and palliative, to see whether services are designed in an integrated way across the main delivery platforms with the appropriate relevant referrals and counter referral protocols and integrated care pathways, whether the linkages are made with the community health works and other social services, whether facilities have quality improvement processes in place, and again, particularly in this time, whether they're meeting this resilience. And we have developed and worked with a lot of experts to define some criteria for measuring, assessing resilience at the health facility level. And ultimately, if countries then can establish baselines and targets for these against these, then we can start to look at hopefully improvements in access and equity in access, and whether their comprehensive services are available at the point of care closest to where people need them, whether the services are responsive to patient needs, and that the provision of care is effective and based on adherence to standards, etc. And so moving across then, ultimately, you want to know whether the policies, the primary healthcare reforms and policies, the investments in primary care capacities resulted in better performance of primary healthcare, resulting in equitable access to healthcare and improved health coverage and outcomes in all people. Next slide, please. So the intention is not to actually be able to really read this slide, but it's really to show you this is the basket of indicators, the menu of indicators that have been identified through a long process of consultation with many, many experts in countries to support this kind of addressing these kind of questions across the results chain. As I said, many of these indicators are already well established, and many countries are already collecting and using these indicators. But there are some new proposed indicators that countries can perhaps find useful, particularly around this selection and organization of services, integrated services, patient pathways, gatekeeping, around multidisciplinary team-based organization, etc. And then moving across really to some of the quality of care indicators, which have been difficult to measure in the past by many countries, but also looking at those traditional primary care functions around the first contact, continuity, comprehensive coordination, and people-centeredness. So we have, as I said, we have developed this menu of indicators. They've been prioritized into categories. Core indicators are identified as we think that most countries would be able to collect and track and use those indicators. The additional set of indicators, which we deem feasible and desirable, that we deem relevant and desirable, but maybe not feasible by all countries. And so, but for those countries who wish to use those, they can pull those down. And then a small set of global indicators that we will propose for global monitoring, which are still at the finalization stage. Next slide, please. And this is just to show that alongside that, then we can also then lay out the indicators around outcomes and impact. And a lot of those come from the UHC monitoring framework that PAHO has just proposed. So next slide, please. And just to say a word on that, the intention is not to use all these indicators, but to select on based on the priorities and needs and maturity of country systems. So finally, the framework also provides some guidance recommendations for how countries can implement the PHC performance measurement framework at national and subnational level, aligning primary healthcare monitoring within the existing national health sector plans, strategies, and review process, tailoring the selection of indicators based on the priorities and the maturity of the health system, establishing baseline values through either analysis of existing data and rapid assessments to address some data gaps, and the setting of country-specific targets for primary healthcare. And then identifying and addressing major data gaps, which might persist. And in that, WHO and PAHO are working on a set of tools to address some of the known areas that are challenging around quality of care, patient experiences, etc. Of course, one of the main things is all about strengthening capacities at national, subnational levels and data analysis, communication, and dissemination of the results. But more importantly, is to integrate and use those results in the regular process of policy dialogues, policy reforms that really are the venue and the forum for guiding actions, interventions, and investments for performance improvement and management in primary healthcare. So next slide, please. Which is just to say that the framework, we will be having an online consultation with member states over the summer this year, and then we hope to publish it in September 2021. And I'd like to thank you for this opportunity. Thank you for attention, and muchas gracias.
Muchísimas gracias.
Thank you so much, Catherine, for your eloquent and simple presentation of a framework which could seem complicated at first glance when we see the indicators of performance, but as you very clearly said, this is a tool that will help countries define the indicators that they use in order to link and strengthen their monitoring capacity and the performance of the objectives. And this will complement the framework of universal health monitoring presented by James. Thank you so much, Catherine. I now give the floor to Sebastián, Dr. Sebastián Garcia, Director of the Department of Evidence and Intelligence for Action in Health at the PAHO. He is a surgeon and a professor at the University of Mexico. He also has a master in health policy, has degrees from the London School and from the Tropical Medicine University in London. He has a lot of experience in working with the health systems and with working with health challenges. Today, he will present a presentation on monitoring oriented to equity in the context of universal health. Thank you.
Thank you all the HSS team for inviting me to participate in this very important session and allowing me to be here with all of you this morning. I want to start. I'm going to share my screen really quickly. So just if someone can confirm that you're looking at my screen.
Sí, se mira bien.
Perfectly. I want to start by thanking my colleagues from EIH, particularly from the Health Analysis and Equity Metrics team, Oscar Mujica and Adrian Cox, for their support in preparing this presentation that is going to touch upon these 6 items that complement both presentations that preceded me, showing this vision, this perspective on how these frameworks then interact with what is happening out there in terms of the social determinants, and of course, what is happening in terms of equity and its measurement, particularly in the context of the COVID-19 pandemic. So the initial statement is pandemics are not socially neutral events. And this is something we've known for a long time. This is an example from the influenza pandemic back in 1918, where we could see how the pandemic affected populations disproportionately based on, for example, income, or based on how they were related to being poor, very poor, or the better off. And this shows us what is something that still happens today. And it's of course linked to this, which is the framework for the social determinants of health, where we look at the structural and intermediate determinants and how this permanent link, this permanent interaction that constitute then their presence as social determinants of health inequities and social determinants of health, and how this should be then at the center of everything that we do, every decision, every policy making that is happening, and of course part of what we measure and its incorporation into information systems and the way we monitor health and the way we monitor the actions that we develop in any way. So as an example of this, this is the evolution of some indicators related to the sustainable development. And I present here the change in between 2000 and 2019 in economic, social, and environmental dimensions. And we see that there's been very little change in this in these 19 years. If we look at the economic change in terms of wealth, the GDP per capita, and how distributed in 5 quintiles, there is no much differences in these 19 years. But the same is happening in the social dimension when we look at education in terms of years of education attained, or even in environmental dimension as we look at access to basic sanitation, and still this persistent inequality in terms of how this is distributed in 5 different quintiles. And this is linked to also what is happening in terms of how we achieve results. So this is before the pandemic. This is how we've reached great results in terms of some of the indicators linked to the SDGs. This is, for example, maternal mortality, and how we had a outcome of 101 in 1919, reduced to 51.7 in 2015. But if we look child mortality, we can also see this great reduction in between 1919 and 2015. And even if we look at tuberculosis incidence with this great reduction. So there is improvement in regional averages. We're doing something. There's an impact that can be measured and can be showed. But if we looked into what's happening in how these results are being distributed in different groups within populations, then we see that there is no significant change in how this is affecting different populations. So we still have this inter-country gradient as we look this using human development and the Human Development Index. And this is something that, of course, conditions what we're seeing within the COVID-19 pandemic. This is the inequality gradients in SARS-CoV-2 prevalence in Brazil. And how, if we look at the graph in the left, we have greater prevalence in the poorest quintile than in the richest. We see this in two different moments as something that persists within the evolution of the pandemic. And we also see how it affects then different populations based on racial or ethnic identification. For example, here, the difference in between white, brown, black, Asian, and indigenous populations in Brazil. So this is how SARS is affecting. So the infection, the prevalence of the infection in different populations. But if we look also then at survival, so how is the probability of surviving from COVID-19 in different populations? And this is Colombia. And we see these great differences in between populations, whether we look at ethnicity, here being the Romani populations, the most affected, whether we see socioeconomic status in the middle, where of course the lowest, very low socioeconomic status are greatly affected with lower survival curves, or whether we look at health insurance, for example, linking it, of course, to understanding the monitoring of universal health and the monitoring of primary healthcare and health systems. So here again, not having an insurance is linked to worse outcome and lower survival rates. So there's a clear evidence on how all these different elements that persist in the inequalities that have been present for many years and that we have been having little impact in their reduction over the time. Now we see it as they affect also within the pandemic evolution and how it affects different populations. If we look then at impact, and this is excess mortality, so looking at the excess of death within a particular population. This is Lima city in Peru. And we can see how, again, comparing the poorest quintile and the richest quintile, there is a clear, very significant difference in this excess mortality, signaling then the difference on the effect, the impact that the pandemic is having in these two different groups within that particular context in the country. And this relates also to this, and going back a little bit on the social determinants framework and how we structure then responses that understand this and understand the characteristics of our populations at the local level, the greater difference and the different barriers that our populations face. So this is linking, for example, on the left, mortality. This is general mortality to average years of schooling, and how this, again, it's seen during the pandemic, even an increased spending of this tendency. And also in terms of the percentage of households living in overcrowded situation as an indicator of this of our social determinants and the inequalities present in the population. But if we look at the right, and this is the percent reduction in mobility. So how much mobility is reduced in a particular context, and this linked, of course, to the instructions of stay at home and reducing mobility as part of the response to the pandemic. And we see how, as there is a greater poverty within a community, and this in this case is the measurement of the multidimensional poverty, percentage of households in a particular level of multidimensional poverty, we see how this reduction in mobility is less. So as people don't have, for example, social protection, or they don't have any protection over their income, and they have to go out, no matter how strong the indications and recommendations to reduce mobility in light of a pandemic and the measures to contain transmission, it becomes less possible to have so. And of course, this relates to then how this affects different people. So it's not just barriers in access to health services, or barriers that could in a moment prevent a person from accessing health systems, but also how people can take the measures, the different measures that are being implemented to respond to an epidemiological event, and that affects then their health in response. This is impact. So this is how the pandemic has hit in something which could be considered a resultant of. This is life expectancy. This is the United States of America, where we see the reduction of an average of one year in this life expectancy at birth for total population. This is already something measured for 2020. But we see how this is different depending on particular populations within this same context in the US. So for example, the Latino populations have a reduction of over 3 years in this life expectancy, or the Afro-American communities, the Black communities have a less impact in terms of year, but they already had a more a lower life expectancy from even before the pandemic. So this sets us back in the progress we had made, at least in life expectancy in many ways, and also signals some of the elements that will need to be looked as we move forward from COVID-19. So what are other elements to look at? This is when we speak about social capital and the relation of with determinants of health and what is happening in the pandemic. So if we understand social capital as a factor that combines social trust, group affiliation, civic engagement, and confidence in state institutions, and we look in the graph on the right, how as the social capital average index increases towards the right, we have a decrease in this crude COVID-19 mortality. So the larger the social capital and what we construct within societies, the less impact, there's a reduction in the impact from COVID-19. And this, of course, represents an opportunity for societies to build these environments in which individuals can construct a solid relationship and confront or respond to health challenges in a more efficient way. So now, what we know in general terms from evidence that have been produced since the beginning of the pandemic, we know that disadvantaged groups are more negatively impacted. And this can be seen, as we were seeing in some of these examples, through higher COVID-19 infection rates, worse COVID-19 severity, lack of access to treatment that James was mentioning as well, with service disruption and other elements, higher COVID-19 mortality rates. And we also see health gradients that could be by employment category, where we see higher infection in employees than managers, or health gradients as well by race, ethnicity, and identity that we were showing also in some of the examples from Brazil and in Colombia. And negative impacts have been associated greatly to poverty and reliance on daily wages or the informal economy. And this, for example, linked to the mobility graph that I was showing earlier, where if people rely on these daily wages for sustaining a family, then it's very hard for them to also take these mobility restrictions or other measures that have been linked to the containment of the pandemic. To weak social assistance programs, deprived housing and deprived public areas and public services, poor health coverage and poor access to healthcare, poorly paid and poorly supported working conditions, and of course as well to poor or inappropriate information, where now the infodemic has had also clear impact on this and has expressed the great need for populations to be able to have access to better information and make informed decisions. So what are those impacts associated with the economy? Well, if we look at what's going to happen and what's been happening already in terms of poverty, so we have, if we just look at poverty, there's a regression of 14 years, and even more if we look at extreme poverty, as we see in the graph on the left. And this is also linked to a 9.1 reduction or regression in the GDP growth rate in the Americas. And we can see that this is a effect across the entire region, with some countries having even higher levels of this regression in the economy. And also in terms of the income inequality, the Gini index for the region is expected to increase 4.9 percentage points just from 2019 to 2020. So as we look at this relationship and what's been happening, COVID-19 and particularly the transmission of SARS-CoV-2 dynamics unveils and exacerbates social inequalities. So neither the exposure nor the susceptibility to the infection agents is distributed in an homogeneous way in the population. They disproportionately concentrate in socially disadvantaged, vulnerable, and excluded groups. And this is part of this, what needs to be permanently monitored. The underlying social inequalities fuel SARS-CoV-2 transmission dynamics, and this is linked to the lack of access to healthcare and to quality information in the socially disadvantaged, that leaves them more exposed and more susceptible to the infectious agent, as we were seeing as well. And the short, medium, and long-term consequences of the COVID-19 inequalities endemic are structural, multidimensional, and intersectional, and it's linked to many of the elements that we do from health systems and that need to be monitored as well. So there's a sense of urgency to address and eliminate unfair inequalities in the opportunities for health and well-being. And this is being fueled by the emergence of this new coronavirus pandemic that has exposed in a dramatic way and has amplified the social inequalities and the the health inequalities. The road to the SDGs, the road to 2030, is now considered a post-pandemic road. And as such, society as a whole should review and rethink its priorities towards building resilient systems to combat future pandemics. And this is something that needs to be included also in the monitoring frameworks and in the way in which we conduct this monitoring. And also linked to the way in which we structure and strengthen our information systems for health so that we capture the necessary information to be able to monitor all these elements and provide the indicators that allow us to rethink or provide the feedback necessary to change our policy and to change our actions. Health policymakers then must recognize the primacy of the principle of equity, where equity is a societal value with a central role in social decision-making, the conduct of civilized life, the identity of peoples and institutions, and the promotion of population health. In this post-pandemic future, health policy, accountability, and pro-equity decisions and actions will be better informed if guided by explicit measurable goals for health inequality reduction elimination. And I'm very happy to see that both frameworks that were just presented incorporate this as an impact and something to be directly measured to monitor and provide feedback on how we progress as a society in the construction of health systems and the response to health challenges. With this, I finish, and I thank you all for your time and your participation, and give back the floor to Amalia for the conduction of the next stage. Thank you, Amalia.
Muchísimas gracias, Sebastián, por la presentación, que la verdad...
Thank you, Amalia, and thank you very much for the presentation, which actually places the two first presentations into a reality which has an impact on us at this time, which is the situation in which our countries are as a result of the COVID-19 pandemic. So thank you very much. And with these three presentations, we complete our presentations and we open the floor for questions. So you can ask your questions in the chat. And in the meantime, I will be checking. We have some already uploaded. And I think we could start with that until the others interested in asking questions put them down. The first question I have here is for Catherine. Catherine, could you comment on how WHO plans to support the countries in the use of the monitoring framework of the essential primary health care, public health functions, sorry. And what's the position of this framework regarding the priority or vis-a-vis the priorities of the WHO? Catherine?
Thank you very much for the question. Yes, so I think in the next couple of months, and as we plan to disseminate this framework through all of our WHO country offices and then to the ministries of health and the other ministries and national governments, then the plan really is that if countries are request or need support to implement different aspects of this, either in choosing the indicators and setting the baselines or and setting the targets, in supporting some of the analytical capacity building that's going to be required, that we will work with the regional offices and through the regional offices to provide the technical support that is requested from the national governments. And that is something we do very much in coordination and under the guidance and leadership of the different regional offices. But technical support will be available to help countries implement the primary healthcare framework and contextualize it and tailor it to their own contexts.
Gracias.
Thank you. And she is muted. Amalia, you are muted.
Amalia, perdón, estás en mute. No te podemos.
Amalia is muted and we cannot hear her. Oh, I'm so sorry. I forgot to unmute my microphone. This always happens in these webinars. I apologize. The second question is for James. Similar to the question they asked Catherine, James, how is PAHO planning to support the countries in implementing this monitoring framework for universal health?
Yeah, thanks very much, Amalia, for that question. So as you know, the Pan American Health Organization, we have our technical programs based in Washington, but in every single country office, in every single of our country offices, we have teams of advisors that work collectively to improve the health and well-being of our countries through joint action with the national counterparts. One of the core functions of the organization is really research, and as part of that, the important element of evaluation. And so it is through the technical cooperation programs that are developed and implemented through our country offices jointly with the national health authorities that we will be implementing and will continue to implement the rollout of this initiative. Obviously, it depends very much on the particular political opportunities that we have within countries, the certain moments in time that present to us also in terms of the application of the model of the monitoring and evaluation framework. And I actually believe that this is a tool that can be really effectively applied as countries begin to think about the future of their health systems, the necessary transformation that they need to take, so that they have that baseline information that they can examine and look at in terms of the output, outcomes, and impact of actions that they have taken that will guide them to improve the health and well-being of their populations in the future.
Gracias, James.
Thank you, James. And we have a question here for Sebastian. Sebastian, could you mention or comment on the disaggregated data by sex and the gender implications within the groups of wealth, ethnics, and mobility? Sebastian. Thank you, Amalia, and thanks, Kathy, for the question or comment. It speaks of the importance of having disaggregated data in many of the topics we attempt to evaluate or monitor in the construction of our health systems, and of course, in the definition of public policies. The data presented referred most to particular studies that sought specific elements within these conditions of inequality, which could be arising within the context of the pandemic. But we have to turn it into data that are continuously and systematically collected within the structures of the information for health in the countries, whereby we can not only consider these general aspects of for example, economic distribution or income distribution or mobility or what have you, but also cross-cuttingly amongst all the different elements, the different gender considerations. And what we've seen here is that in constructing the information systems, often the availability of these disaggregated data barely exist or they're very poor quality. So there's really no way of using these stratifiers that would allow us to constantly monitor progress in the different populations, particularly as we lower the levels from the national to the subnational levels, or if we begin to see how it affects specific populations. We see differences, for example, in the way in which we ask about very important elements such as gender and the gender considerations within the countries where there is no standard of how to ask or how to consider this element. And the same with elements such as ethnicity, where there's a fluctuation between the self-identification of the, say, indigenous groups in our countries or the speaking of indigenous language as a proxy for this. So we have a long road ahead of us in strengthening these information systems so that we can actually obtain these data and use them as we would need within the monitoring and evaluation frameworks for continuous feedback. So I thank Kathy for this comment and for the chance to point to the importance of this. Thank you very much, Sebastian. And really a lot of things to do. I have another question here for Catherine. And it is in English, so I'll read it.
In the basket of indicators presented in relation to the UHC monitoring framework, I notice an absence of indicators on health inequalities. Is WHO considering measuring and monitoring these inequalities across the different dimensions of the monitoring framework? And if so, with what indicators and how? Catherine?
Yes, thank you. Thank you very much for the comments and for the questions. I mean, I think the challenge of monitoring equity and inequalities is extremely, as you say it is. I mean, we don't really have many opportunities in the current data systems that look at these inequity measures. Of course, household surveys do look at those dimensions of wealth and place of residence and education and gender, and we need to draw on those. But they are usually related to the outcome and impact indicators mostly. And so throughout this framework, we have tried wherever we can to ensure that when we are talking about policies, or different indicators, that we're looking at the different equity dimensions that are possible. So for example, when you're looking at PHC policies and PHC and frameworks, that we're looking at whether the vulnerable groups and the target, the most at-risk populations, whether and by the different groupings are included in those policies or are targeted in those policies, whether the allocation of finances is looking at those kind of most vulnerable groups, etc., and whether the package of services that what countries would provide or addressing the needs of some of these most vulnerable and hardest to reach populations and groups. So the equity dimension it kind of goes across all of these indicators and all of these measurement domains, and then needs to be brought together in the analysis through the analysis. And I really like the presentation of the last presentation, where it shows, well, when you have some of these equity dimensions, then we can start analyzing and look at these groups. I think many countries do, there are disaggregations around geography and around urban, rural, residents, but there's not enough around things like migrant populations and refugee camps and internal displacements, and we really need to improve that from the policy perspective, in the financing, in the definition of the services, etc. So the equity is across the whole network and across the whole framework, and each indicator we've in the chapter, one of the chapters of the framework, we dedicate to measuring equity and where you find all these dimensions within the system. However, I think one of the things is I think countries need to set targets for reducing inequities in their country. So make it an indicator. rather than just as a disaggregation of other indicators. And I think that discussion needs to happen around the setting of baselines and targets. But I mean, it's a great question and great comments, and I think it's something that we need to continue to learn and work together within countries to explore the innovations there and how that can be better evolve going forward. Thank you.
Thank you, Catherine. And I'm going to take the opportunity that there is another question for you, and it's quite simple in terms of the answer. So is the monitoring framework available at the moment?
For primary health, is that for me, Amalia? Oh, okay. Yeah, so we have an advanced draft. It's not quite final, but it can circulate as an advanced draft if countries or people are interested in looking at reviewing it, testing it. It will be finalized in the next month or so, and then published before September, by September. But we will make it available as a working document to our colleagues in PAHO, and they can make it available then to those who are interested in having a look, recognizing it's not completely final.
Thank you, Catherine. Tenemos,
and we have another question here for James. There is a mandate, a PAHO mandate, to work with other agencies in the countries to implement these operational frameworks and in general of APS, or is it in general, or is it only exclusively a PAHO function?
No, so thanks for that. Thanks for that question, Amalia. You know, PAHO is the lead agency in public health through the Inter-American system, and is the regional office of the World Health Organization in the Americas. But this does not mean we can do it alone. To the contrary, we really aim to work very closely with all our partners within the UN system, across government, with academia and with civil society in the implementation of the policy guidance that we provide to our member states. You will note that if you go back to our governing bodies documents, where let's say if we look at the strategy on universal access to health and universal health coverage, there is always a section within these documents that where countries request the director to do something. And always you will find in there that it requests the director of PAHO to seek to improve the level of partnerships and the collective action across all sectors to achieve the implementation of the mandates of the organization. No more. Primary healthcare is really one of the areas where this has to really happen. We cannot just have action within the health sector. Obviously, it's important that we build the resolutive capacity of the first level of care, and we integrate within health services networks. But if we're looking at health financing, if we're looking at addressing the social determinants of health, if we're looking at improved preparedness and response, if we're looking at social protection, all of these imply partnerships across sectors and with our multiple partners in countries. And that is from one of the principal, I think, areas of work that organizations, particularly with the UN coordination team, but even outside of that, ensures to achieve in delivering technical cooperation at the country level.
Gracias, James. Creo que aquí hay una...
Thank you, James. I think that there is a question here. Well, there are two questions that I can leave open for comments from all three. One has to do with, in the opinion of the speakers, how do you assess the impact of COVID with regard to the rights of children and adolescents in terms of quality of life, access to health services and education, and the consequences in the field of comprehensive development? Actually, they have very little to do with the framework itself, but they do have to do with what we do and how we use the information. So I leave it open for comments from whomever wishes to answer. I don't know who would like to comment. James, would you like to add something maybe? And then after Sebastian, and maybe Catherine also might have a comment
Yeah,
after.
no, thanks, Amalia. This is a really difficult question, and I see it was actually posed by Elia. So a very good morning to you, Elia. And it's a really complex issue. I think those of us who have children, we have witnessed this firsthand during this pandemic. The challenges that have been faced by our kids in ensuring access to the necessary health services, be it through a regular checkups, a primary care consultation, updated immunizations, but also just the overall impact in which the public health measures have had in terms of their social development, contact with other children, access to their peers in a school environment, and of course access to the necessary education that is required. It's interesting to see that at least some of the empirical evidence, depending on the capacity of the educational system to be able to provide remote learning, matched and linked essentially with the, I suppose, individual characteristics of the individual and the environment in which the learning is occurring, is having reporting distinct outcomes. But mostly, I think there is general consensus, although the evidence is very empirical at this point in time, that we've seen significant increases in mental health illnesses and potentially developmental issues for children, particularly I would say at the younger age, but also within the teen years. This is something that I think when we talk about the recovery phase, as we move into the recovery phase, and we talk about the recuperating of lost public health gains, that we do need to have a differentiated approach where we talk about differentiated needs of specific population groups. I think we do need to be looking very carefully at what has happened to youth and to our children during this pandemic, and to be able to develop those differentiated strategies very, very quickly to be able to address the needs, the needs moving forward. I'll stop there to also pass over to the other panelists, Amalia.
Thank you, James. Sebastian? I agree. I agree with James in that this pandemic has had a direct impact on the youth and adolescent populations. And we still haven't even really seen the final results of all this. This is just an ongoing situation. And the closure of schools, where often the educational aspect, but not only that, because they also have access to different types of food support or even support in safe environments that helps in their development. And they've witnessed many closures as a result of the pandemic and as part of the different actions to contain this pandemic, which I'm sure will cause an impact. We still have not been able to quantify it. We've still not been able to see what has been the actual impact of these policies that have generated barriers to what the children had access to in the educational environment and in these environments of the school in general. So this is something we have to see very carefully and keep it in mind as part of the response. Health will have to build to respond to these needs and this recovery that James is talking about post-pandemic, and to include it within the measurements that we have as a follow-up or monitoring of the impact of COVID-19. Thank you, Sebastian. Catherine, do you have anything to add to this question?
No, thank you. Thanks, Amalia.
Thank you, Catherine.
Thank you, Catherine. So I have here another question, which I think is also open, and you can freely take the microphone and respond. The question is whether PAHO already has strategies for the countries to adopt measures to reduce the gaps in social inequalities.
Les paso el micrófono.
I give the floor to whomever wishes to take the floor and answer this question. Yo,
James unmuted himself first.
James.
Okay, thanks. So, I think equity is, Sebastian made very clearly in his presentation, equity is at the heart of everything that we do. And so that quest for equity is central to the policies and strategies that are developed and adopted by member states, and that we work very hard for in terms of the delivery of technical cooperation to our member states. It's reducing those gaps that I think came out very clearly through Sebastian's presentation that we need to be focusing on to make sure that those persons and populations living in conditions of vulnerabilities have the necessary capacity and are provided the access and coverage required to health as countries continue along the economic and development pathway. What we have seen in COVID-19 is that those vulnerable populations have been impacted the hardest, whether they're Afro-descendant populations, indigenous populations, women, which constitute the higher percentage within the informal economies, obviously the poor, those living in peri-urban areas. And so coming back to our previous point, the strategies for recuperation once again needs to be very much focused on accelerating recovery within these groups. This year we will be discussing within governing bodies of PAHO a strategy for resilient health systems. And the strategy for resilient health systems builds an approach to really strengthen governance and leadership within countries to address these issues, to reduce inequities, and to accelerate recovery and recuperation of lost public health gains through 3 areas of work. And I think these 3 areas of work really speak to the issues of reducing these inequities. First of all, primary health care, as Catherine very clearly presented in terms as the strategy for reducing inequities and addressing the needs of populations where they live. Secondly, improving the application and capacities in the public health functions, which once again, through intersectoral action, needs to address the differentiated needs of populations, not just in terms of their health needs, but more broadly in terms of living conditions. And finally, to look at the issue of financing, financing health, but also financing social protection and the social protection mechanisms that protect those populations that are particularly more vulnerable. So I think this issue is really central to all the work that we do at PAHO.
Yo me permito complementar, Amalia, solo con...
If I may, I would like to add a couple of comments coming back to what James was saying about reducing gaps, which is the center of everything we do at PAHO, all the different areas and programs. What is fundamental is to show these gaps, to make them visible. If we are unable to determine where are these vulnerable populations, where are these persons who are in a situation of vulnerability, and which are the elements that generate the vulnerability, it is going to be very difficult to resolve these gaps. So part of the efforts that we make on a daily basis at the organization is to generate the country's capacity to have data and information about these groups in order to make these gaps more visible, and also to work to develop capacities to analyze the data. So it's not only an issue to have data, but you have to be able to analyze them. And this is what comes to the framework that we have created with attention to SDGs 3 and the element of equity. And this is what has allowed us to work with the countries at the national level, not the big national aggregate figures, which sometimes hide what is occurring inside the country at the regional level. So we would have a vision that will allow us to see specific problems. And also the same applies to vaccination programs and communicable diseases, chronic diseases, where we are trying to understand the specific characteristics of certain populations and to design policies together with the countries and help them to build these policies in order to cope with these problems and taking into account equity. Thank you so much, Sebastian. I have a last question for you, Sebastian. It is quite specific. Which recommendations could you make to improve the surveillance systems with populations that have in the mobility area? This is not a new subject matter, but the pandemic has highlighted it. There are migratory flows that occur between borders in the region and what this has represented as far as the burden on the health systems and the need to have better monitoring, better data on the mobility of the population. And this is how we have created the possibility of have links of observation, use new technologies in order to know better the health situation of people through the monitoring and surveillance systems that allow us to share information beyond borders in a format that is compatible and standard, and this should be part of the monitoring system, and also to see what is occurring within the countries as far as mobility of persons that are not necessarily going across national borders. So the big migration movements that occur within countries and that also generate a problem for the provision of services and the barrier to access the services. So we need to be able to visualize them and learn about them. And this is part of the building of surveillance systems that should allow us to know people within their communities, develop the appropriate diagnostic in health, and then to follow up on them throughout their lives, including when they are in a mobility situation. Thank you so much. I will give half a minute or 1 minute to each if you want to send a final message before I close this meeting. If you want to, do you have a final message?
Just to thank you and all the panelists and the participants for being here this morning. I think the final message I'd like to leave is something that the former DG used to say of WHO, and that was what doesn't get measured doesn't get done. And so I think as we move forward in looking at this important monitoring framework, I think it's very important that we begin to roll this out, apply it in our countries, and really help countries then work with them on the necessary policies to improve access to health and coverage.
Gracias, James. Sebastián.
No, agradecer, Amalia.
Thank you, James, Sebastian. Amalia, I wanted to thank you, the team that organized this forum of the development of the framework. We thank James, of course, for the invitation and for the possibility of showing this, and the invitation to all of us to take a very objective look at our information systems and the need to strengthen them in order to attain what James just said, to really be able to see what is going on and measure our progress and thus be able to provide the necessary feedback. If we do not have this construct of information systems which are strengthened and which allows us to follow up, it is going to be very difficult to apply our policies to improve our systems and to close the gaps. So once again, I thank you so much for the opportunity and thanks to everybody for the participation. Thank you, Sebastián. Catherine?
Well, just to re-emphasize, I think just the last comment, I think is so important. We can talk about indicators and we love to talk about indicators. and spend most of our time talking about indicators rather than investing actually in the underlying data systems and the underlying capacities. And I think there is opportunity now. There's momentum now. There's a need right now to help do that. And I think there was a question that we have developed better innovative tools and methods to address some of the gaps from before. And we work with the PAHO and the regional office to help support, provide those to countries to help address some of those gaps. But more importantly, I think learning from countries and some of the innovations, learning from your experiences, documenting those experiences of how you're actually addressing some of these issues, the gaps, and the use of the data to drive action and to drive the investments and improvements. So that's all. I'd like to really thank you all. Thank you to the PAHO team, to James, Amalia, Sebastian, and the whole team. And thank you to all of you that have participated in this webinar. And maybe hasta luego. That's my Spanish.
Decimos, Catherine, hasta pronto.
Thank you so much, Catherine. Thank you to all three of you. Your presentations were truly excellent and they complemented each other. I would like to say that in the chat, we didn't only have questions, there were several comments with thanks and congratulations. So I thank you, all three of you, for your presentations, and I thank the colleagues that have participated and thank them for continuing to participate in the series of seminars of the strength of the essential services. We have had almost 500 participants today between Zoom and YouTube. So as I was saying, this is an issue of great interest, especially at this time. What we do not measure is something that we do not see, and we can also not be accountable for it. And that is an element that is very important with all these processes that allow us to understand. James, Catherine, and Sebastian have highlighted the importance of monitoring and assessment. And as Catherine said, we don't want an indicator just to have an indicator, but these analyses allow us to understand which health policies work, which health policies do not work, how are the health services performing, always taking into account our goal, which is universal health and equity. Monitoring, in addition to being part of the policies and health policies, is an essential element in order to have accountability systems and to guarantee a social participation which is genuine and inclusive. And that is one of the central elements of universal health.
Con una búsqueda de un objetivo que es un objetivo
So we have to see how we can do this with an objective that has been constructed for this situation in mind. We have also heard in Sebastian's presentation, although we heard it by all three participants, about the challenges that are faced due to the pandemic and how even within the context of the pandemic, it is even more relevant, the element of monitoring, assessment, and the development of information systems which can provide real information in real time in order to support the decision-making process for the strategy and also at short term in order to have an adequate response by services within the pandemic. Universal health for everybody, everywhere, even during the pandemic era, requires strengthening an intelligence of the health service, that is to say, the analysis of situations of the health of the population, elements which are central elements of the essential public health services. That intelligence capacity, which will indicate which are the inequities, the obstacles, the specific needs, and differentiated needs amongst different parts of the population. In the 21st century, we say we still have difficulties in obtaining information per age and gender. This is really a shame in public health. I am not talking about individually doing this for us. I remember that when I was studying preventive medicine, this was classic. We need to know age, gender, and place of residence. So these are very complex procedures, and although we have a high development of technology, we have the frameworks, we still have this type of challenges in our countries, and I think that definitely we hope that as these tools are used by the countries and who are cooperating and they are adding it to complementary measures, we will be able to start closing these gaps. So I ask you to look at the web page, look at the framework of monitoring. We are going to translate into Spanish the 3 presentations, and we are going to publish them in our web page, but especially the document on the framework for universal health is already available in English and in Spanish, and it is a very important tool for us in order to prepare the agenda for the strengthening of the essential functions of public health and the most important functions when we're trying to look at the essential functions in health, public health. With these words, we want to say with optimism, with a commitment that we will continue cooperating and making progress in this work, which is always a pending issue and with new challenges every day. I thank all of you for your participation, and I will see you in our next seminar. Thank you very much, James, Catherine, and Sebastian, and thank you so much for the team, all of those who are not on the screen who have helped us. Thank you so much. Thank you.
Buen día.
Thank you.